end up taking this down while I talk and putting it back when I'm not. Welcome to our special Sioux Falls City Council meeting. Appreciate those of you who are here. We have a very limited audience in the room. We have, I'm sure, a lot of people joining us online as well. Kind of to call the meeting to order, I'm going to ask for the roll and the Pledge of Allegiance like we normally do. I want to go through a few housekeeping items here. Per council policy, public comment will be taken after each staff presentation today. So we have 3 of those. Those will be limited to no more than 5 minutes. People are asked to keep
joined the meeting.
People are asked to keep their remarks limited to the item that's being presented. I ask the audience to observe social distancing to the extent possible. I will ask that speakers not touch the mics on the podiums. Also, the chairs are spaced 6 feet apart. I ask that you leave them there and not move them into the chambers or not move them in the chambers or in the overflow room, please. I want to remind you that those in the audience and those watching at home that all meetings can be viewed on Midco channels 16 and 594, and on VAST you can see us on 11 and 511. Additionally, you can view a live web stream at siouxfalls.org/live. Lastly, some of today's presenters will be joining via video conference rooms that are set up here in Carnegie Town Hall and at our Emergency Operations Center. There continue to be 3 council members joining electronically as well. So we're doing our best to facilitate social distancing here at the dais and in our seating areas. So that will get us started today. Tom is clerking behind me here, and we'll ask him to get us started by reading our roll.
Councilmember Selberg.
Here.
Sale.
Yep.
Starr.
Here.
Staley. Brecky.
Here.
Erickson.
Here.
Kylie.
Here.
Neitzer.
Here. All right, I'd ask that you stand for our Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, so again, there'll be no actions taken today, no votes taken. This is just a special meeting, but for informational purposes only. Our first topic is to get an EOC update, and I'm going to ask Regan Smith, I think, is leading that, or Jill. Jill's leading that, so I'm going to invite Jill forward, please.
Good afternoon, everyone. Jill Franken, Public Health Director with the city, and I'm only going to just give you a little bit of information before I hand it over to Regan. First off, I want to thank Tom Greco after Wednesday night's council meeting. They've made a lot of changes in here that I think were important changes to make, and so him and the team of the city that really took some time to creatively think about how we can conduct business of the city and still be safe, I think is really good, so thank them for that. Just to give you a quick intro here, just want to remind us that we had 93 new cases today in Minnehaha County of COVID-19 infections. We had 6 new cases in Lincoln County. So total in Minnehaha County to date is 1,157, and Lincoln County 77. That equals 1,234 cases in our 2 counties. One of the things that we've been working on, I've talked to you about our operational objectives for our incident action plan of the Emergency Operations Center. We have been working this week to revise those for this next operational period, and I think it'd be good for you to know what those are going forward as we continue to move through this response. This has been with input from our EOC leadership that includes Regan and Sandy as those emergency managers that really monitor and manage the EOC, as well as Unified Command has reviewed these and then have had these reviewed and edited as necessary by our city leadership, which has also included our city directors. So as we move forward with this, the work that we're going to be doing, the first objective is really to review, assess, and implement the public health measures necessary for COVID-19 management. The second is to coordinate with healthcare agencies to support, expand their services and capacity. The third objective is to provide coordinated and proactive public information about COVID-19 facts, risks, and protective actions. So a lot of that we've already been doing. We'll continue to do that. Fourth is to coordinate strategies to manage economic impacts to the Sioux Falls community. Mayor Tenhaken has talked about that quite a bit, that we have to start thinking into the future while we're operating under this pandemic right now, and so that's work that will begin in this next operational period. Number 5 is to execute and adjust City of Sioux Falls department continuity plans to ensure continued essential functions can be maintained through various phases, including mitigation, surge, peak, and recovery. And then lastly, to assist organizations that serve, but certainly, it's last but certainly not least, is how do we assist organizations to serve the most vulnerable and at-risk populations in our community. So that's gives you a sense of where we'll be heading next. Those are big objectives, and there will be tasks under each, and those are the things that we'll continue to be rolling out as we start next week, really moving into this next operational period. So with that, I'd like to turn it over to Regan Smith, who's our emergency manager for the city, and he can give you a review of the EOC. Thanks.
Thank you, Mayor, Council. Appreciate the opportunity to give you this overview. This is something we wanted to present over the last couple of weeks, but you've been dealing with important issues, and now is a good time. The COVID-19 planning team was developed and met regularly and started sharing information with our community partners in late January. Our City Emergency Operations Center has been open and operational since March 13, so that's 41 days to date. Consistent with other responses in the city multi-agency coordination team is supporting this response from our Emergency Operations Center. This team is conducting daily operations briefings with over 40 community response partners. We issue a daily situation report. 41 of the reports have been developed to date. We've developed an incident action plan, and that is updated very regularly with those new objectives and operations. And as Jill said, that unified command is setting objectives and priorities. You can look at the org chart, and I apologize for the print there, but it's a big organization, so that's what we've got to look at today. As you look at it, our unified command is made up of our City Public Health Director, Jill Franken, and representatives from Avera Health, their Chief Medical Officer, Mike Elliott, and Sanford Health Chief Medical Officer, Mike Wilde, and it's been a great relationship. They're being advised by public health advisors from South Dakota Department of Health, the City Health Department, and then epidemiologists from Sanford and Avera as needed. Under that, we've got our PIO, and we've developed a joint information group that's made up of the City EOC, the South Dakota Department of Health, Sioux Falls Public Schools, Sanford and Avera Health Systems, the Helpline Center, Bishop O'Gorman High School, the VA Medical Center, Lifescape, Patient Care Logistics Solutions. They're developing our daily news briefings, our press releases, social media infographics, our website, educational posts, as well as answering those direct inquiries from the public. We've also activated the Helpline 211 Center to assist with calls for this information, and again, they're an invaluable part of our response, and they're also leading the efforts for the Unmet Needs Committee in the community. Our liaison officer, which I'm at that role for this incident, is working with agency representatives from Minnehaha and Lincoln County, the court system, Chamber of Commerce, South Dakota Department of Health, Sanford, Avera, the VA, South Dakota National Guard, Sioux Falls Public Schools, Bishop O'Gorman Catholic School,
has joined the meeting.
Sioux Falls Christian, Harrisburg and Brandon Valley Schools, and communities within Minnehaha and Lincoln counties. If we move into the operations there in the red, we've got that divided into 5 groups. The first group is the Sioux Falls Healthcare Coalition, and this is a group that was formed probably about 25 years ago, and it's made of the City Health Department, Avera Health in Sanford, and the VA, and State Health is also working that. That group is dealing with such issues as increasing our hospital surge capacity, development of a possible alternate care site, inventory management of PPE and other critical items, specimen collection sites, and then housing and of isolated and quarantined individuals. The work involved in the management and finance of all these projects is really extremely complicated and continues to grow as this incident develops. Second group is our public safety group, and that's made up of our police, fire, EMS, and 911 system. They've developed and implemented enhanced mitigation and response protocols, additional personal protective equipment, and additional EMS vehicles for our 911 and EMS responders so they can protect the health and welfare of the public and responders. This group's put considerable effort in developing a mechanism to be used to provide our first responders with information to help them manage potential staff exposures. This group is involved in partnerships with South Dakota Department of Health, the Sioux Falls Health Department, the Fusion Center, and a number of law enforcement and fire and EMS agencies. Moving ahead, a third group is our City Continuity of Operations group. This group is working with all city departments in implementing their continuity of operations plans to continue those essential government services while providing the health of their employees as they serve the public. COVID has really changed how every city department is doing their business. A great percentage of the city effort is now dedicated to COVID preparation, mitigation, and response. Vulnerable Populations group, and that's being led by the Sioux Falls Health Department along with Minnehaha County Human Services. They're working with our housing division also and hospital case managers to assist with sheltering needs and meeting needs of vulnerable populations as they quarantine and isolate. City and county are working with local support agencies to ensure the homeless populations are supported and sheltered. And again, that's a growing and developing group that's working hard. Continuity, Community Organizations Active in Disaster. You've heard a lot about these folks. They're coordinating relief efforts for residents through that Sioux Falls Relief Fund, One Sioux Falls Relief Fund, Unmet Needs Committee, and then community food distribution. Finally, we have city inspectors from Health and Planning Services that are proactively assisting businesses with education on mitigation efforts that include such activities as conducting employee screenings, increasing efforts on environmental cleaning, and high-touch surfaces. Those are the operational things. We also have a planning section that is helping us develop situation reports, our incident action plans, and then doing all that work with that data analytics that we're going to see here shortly. And then our logistics section, which is primarily our finance department, is procuring PPE, developing contracts, and securing other resources as are needed, not only for the city, but other response agencies within the community. With that, again, I appreciate all the support of the leadership here at the city and take some questions now if anybody has any.
Thanks, Regan. I'll first ask if there's anyone from the public who wants to talk specifically about our EOC, not about any ordinances. All right, seeing none, no comments on that from the public. Councilors, you want to ask any questions of Regan or Jill on our EOC setup? Councilor Staley?
Do we have a
Mr. Mayor, first of all, somebody's not muted and they're creating a lot of feedback. So if they could mute their phone or stop working near the mic, that would be very beneficial.
All right, thank you. Councilor Staley?
Is that better, Councilor Kiley?
Yep.
Yes, it sounds better now.
I don't think it was on our end.
Thank you.
Okay, so a question that I've got is, Reagan, these slides here, do we have a copy of those?
I'll work with Tom to get those to you.
Okay, yeah, that would be beneficial to have that. And then I was just wondering about a name on the first one, Jeremy Caldwell's. I haven't heard about him.
He's a physician that's working with him.
And what institution is he with?
He's with Sanford Health.
So, okay, because the other two, Avera and Sanford, we've heard of, but I didn't know there was an extra one. Okay, thank you.
You bet.
Other questions for Regan? Any questions on the phone for Regan?
I've got one more question too.
You're on.
And then how's the VA playing into this? I don't know if you're the person to answer that, but we're hearing a lot.
They're part of our healthcare coalition, so they're increasing their surge capacity, and that's part of the overall plan that they can take. Obviously, their primary mission is veterans, but they also have another mission where they can take patients outside of their system if needed, and we're working with them daily and making those plans in place.
Would we ever have a necessity to have them come in and be represented here physically like we have the other two hospitals? I mean, do they have a chief medical officer as well?
So the VA is part of our healthcare coalition, but the physicians who are here are actually with our unified command. Jeremy Cowles has been helping assist if for some reason Dr. Wilde is unable to attend a call. But it's really been primarily Dr. Elliott and Dr. Wilde who've been in our unified command, with Dr. Jeremy Cowles helping in that capacity as well when needed, and so that's why they're here.
Okay, so would Avera ever have someone else stepping up to be, I mean, we've got two from Sanford, would we ever have another one from Avera as well?
We do actually, I mean, we made the decisions that we did regarding unified command, but Dr. Basil is also here on behalf of Avera, and he has been extremely involved in some of the work we're doing around the modeling, and so that's the answer I can give you on that.
Yeah, I think, Counselor, also I could say the VA is more an operational resource that we're working with and less at the unified command level here in this organization. But we are working with them every day, and they're integrated into the system.
Good, and I know the public has asked about how the VA is playing into this whole operation. Thank you.
Other questions for the EOC team? Any questions on the phone? All right, thank you, Regan. All right, we'll move on to our next item. This is, I think, what most people want to talk about, our data modeling review. To kick this off, I'm going to actually pass the gavel to Councilor Selberg, because I want to be able to speak to this one today as well.
Has left the meeting.
Someone's sick of it already. On Wednesday night, our administration brought forth a stay-at-home order for first reading to you as a city council. This proposed ordinance was brought in response to the rapid case growth and spread of COVID-19 in Minnehaha and Lincoln counties. More importantly, it was the result of the data we have been reviewing that showed our healthcare systems could be operating at or above capacity during our peak, which is currently forecasted for mid-May. At that meeting, we discussed how rapidly this situation changes, how data forecasting continues to play a primary role in our response, and how 5 days between a first and second reading can seem like 5 years in this current landscape. This situation and the warranted responses change like nothing I have ever experienced in my professional life. We are in an environment where we as local governments are being asked to be nimble in a system set up to be anything but. Noticing meetings, holding first readings, holding second readings, providing time for new laws to take effect. It's made managing this pandemic at a local level very, very challenging. This morning at 8:30, our Emergency Operations Center, we received an in-depth modeling briefing from the City of Sioux Falls data teams. This data presented is a joint effort of data, information, and assumptions from the state, from Avera, and from Sanford Health, specifically for Lincoln and Minnehaha counties. Again, that's really important. A lot of what you've heard from the state level is state data. What we're going to be sharing you for the first time ever is data specific to our two counties, which is harder to come by than one may think. The council and public will see that same presentation here shortly. In this presentation, you're going to see two key themes emerge. One, social distancing and mitigation strategies have a direct impact on peak hospitalization numbers. The more you do, the lower those numbers. And two, at our peak, again, currently forecasted for mid-May, our healthcare systems, while operating at maximum capacity, feel they can meet the current COVID demand. This is important information to understand as it creates an opportunity for us to determine what measures we can deploy to further flatten the curve and provide our healthcare partners with more of a capacity buffer, while also providing the needed support to the businesses and employees of our community who continue to be impacted by this pandemic. When we alleviate the hospital capacity, we help ensure that life-saving resources and caretakers are available to those who need them when they need them. Remember, we are not stopping COVID. Okay? The reality is people will die from COVID-19. All right? People will need ventilators. People will need ICU beds. People will need to be isolated from their family members. This is a reality that we all need to face, and everyone needs to come to terms with that. What we are tasked with as government leaders is to try and control who gets sick and when, and minimize community damage during that process. It's a near impossible task with no winning playbook, but there are, however, some smart plays that we can call based on the invisible COVID-19 opponent that we're currently facing. Council, I would ask you to review this data here today with a very open mind. The administration's view on what you are about to see is that our current stay-at-home order that you will hear a second reading on Tuesday needs to pivot. Based on today's data, I feel that the measures we still have to take in our city to further flatten our curve can be enacted through enhanced regulations in our existing no lingering ordinance and not via a stay-at-home order. We are currently working on what this could entail, but would likely involve measures to target where the population density is highest through mandatory mask wearing potentially at public businesses, mandatory temperature checks for large employers, large companies, or other potential measures. As we have said throughout our response to this, the city and our administration is relying heavily on our healthcare partners who have been incredible, by the way, and strong data modeling in our response and will continue to evolve as we go. All that being said, public health and protecting lives has been and will continue to be my number one priority in this response. I'm going to read that again. Public health and protecting lives will be my number one priority throughout this entire response. There's no greater duty for an elected official than to protect the lives of the constituents he or she is serving. That is what drives me right now. That is what keeps me up at night. That is why we are sharing with you the data we are going to share today. I am thankful for the sacrifices of every single person in this city and the steps they've taken to flatten our curve and save lives. We have a large number of cases in the Sioux Falls area based on hotspots, as well as more aggressive testing than any other areas of the state and nation. Regardless, the virus is here. Hundreds have confirmed cases and thousands of asymptomatic people are likely present in Sioux Falls right now. Let's be clear about our ultimate goal here. We want this virus gone with minimal damage, minimal deaths, and minimal impact on our economy. Sacrifices have been made and sacrifices will continue to be made in the weeks ahead. We are in this pandemic together as a community. We will prevail through it as a community. Each of us has a role to play, and as a city council, our role is to look at the policies impacting the entirety of our community on a macro level, on what's best for the entire community. I believe the actions we have taken thus far are justified in the proposals before us in the days ahead. They're very necessary for us to consider, to protect lives, but also to sustain this great city. And so with that as a backdrop, I'm going to turn it over to Eileen Proffer with our City GIS and Data Department to walk through the very detailed modeling we are using to make our recommendations to you today. So Eileen, you can come forward. While she's coming up, I just want to reinforce this is another commitment to the transparency of your city leadership. We're going to share with you more data than probably anyone in this room has seen on COVID and what's driving the modeling for Lincoln and Minnehaha County. So we will take questions after this when Eileen is done and move into conversation, and there will be a period of public input time for that as well. So Eileen, the floor is yours.
Mayor, if I can just interrupt one
Yeah,
moment.
Tom.
Eileen, can you use the one labeled clerk?
Got it. Okay, thank you. Thank you for taking the time to be here. I know that each and every one of you have a heart for the people in this community, and that we are asking you to ponder some very difficult decisions. As I walk you through the models today, I'll be talking a lot about numbers, a lot about data, but I'd like us to keep in mind that we are really talking about people, not infections or beds or ventilators. We're talking about family and friends and neighbors. So just to keep that in mind, and before I delve into the details, I would really like to thank you for your patience. I know as we prepared this information, it's not easy to wait for numbers, but several teams have been really working around the clock for weeks to get where we are today. And I want to acknowledge the commitment that we have seen dedicated from like highly capable, intelligent individuals from Avera and Sanford, the city and the state. It's been a long week, but we have been able to work together to get where we are today, and I'm very happy to acknowledge these individuals that all came together to bring us to where we are today. So our goal is to share with you where we're coming from a public health perspective. I will show you the model that was created here at the City of Sioux Falls, and I'll give you a detailed explanation of the parameters that went into using that model. And after that, the doctors from Avera and Sanford are welcome to comment as well. I'm sure there'll be questions, but I'll try and get through all the parameters first, and then just so keep it in your head and hold on to it. If you really need to ask something, feel free. If at any point you need me to slow down, please just say so, because I've been doing this presentation over and over, so it feels like, you know, it's easy for me, but I need to slow down sometimes. So if you can't hear me, just let me know. So I'd like to begin with an image that you're probably all familiar with. It's that flatten the curve graph, and it really represents the impact that social distancing can have on the progression of infectious disease, and nicely illustrates the risk of fatality from overwhelming our own healthcare resources. But I know it's still rather abstract to look at it, right? There's actually no real numbers on it, there's no real timeline, and that's really because flattening the curve looks really different depending on your own local circumstances, which is why it was so important for us to be able to use Sioux Falls or Sioux Falls area local data in our modeling. So keep in mind that graph, that's pretty abstract, and now we can throw in what the models show that we've accomplished so far in terms of flattening that curve. So what you're seeing are the curves produced by the model that we used, and it shows in that kind of, gosh, I don't know, orangey color, where we could be right now if we had not implemented any social distancing. And it also shows the current trend of around 25% reduced social contact in that blue color, and that's where we are trending for expected peak infections. There is a vertical gray line that you can see. It says today on it. That is literally today. And if we hadn't implemented any of the interventions that we have in place right now, this would be a totally different conversation today, because we would be looking at nearly 600 hospitalized COVID patients. So we can pat ourselves on the back that we have already accomplished a lot. And as good as this graph is, it surely can be better. Even at our expected peak in the blue, if we continue on that same blue curve, we're walking a fine line of the quality of care that can be provided at that level of illness in our community and along with the communities around us who depend on our healthcare systems. So we also used our model to project a 35% reduction in social contact, and that's the green curve that you see. And that really puts us at a much more comfortable situation to be equipped to handle the surge of COVID patients. So this is slightly less abstract than that first flatten the curve graph. Yes.
And
Sure. Okay.
there you go.
Right on the blue line now.
Get as close as you can, yeah. We'll give you some grace.
Thank you. Right, so this graph that we're looking at is slightly less abstract than that first flatten the curve graph, but now we've got some numbers and we've got a timeline to go along with it, but how did we really figure all of that out? So the curves that you're seeing are based off of a commonly used technique for modeling infectious diseases. Unlike COVID, those methods are not novel. They have been in use in some form or another for nearly 100 years. And in a very basic way, we can understand the progression of infectious disease in terms of three groups of people. So you have those who are susceptible, those who are infected, and those who have recovered. At the beginning of an epidemic, right at the top where it says susceptible, everyone is susceptible to the disease. There's no vaccines, anyone could get it. And once people become exposed, they move out of that susceptible category into the infected category. And as more people become infected, less and less people are able to be susceptible because they either have it or they've recovered from it. So that is the process that creates the peaks that we've been looking at in all of our graphs. So you can see in the blue where it says infected, that is the peak that we are modeling basically. And that is a very basic, very, very basic explanation of how the models work. Because really all models are simplifications of the real world. And really the real world is much, much messier than three groups of people that move smoothly from one category to the next along a perfect curve. And we have to take into consideration a whole lot of variables that can be difficult to quantify, especially with a virus that's so new. So for that reason, we say that our models are dynamic, and that means that they really do continually need to be reevaluated as new information becomes available. So we see what's happening on the ground day to day, and we make adjustments. But models are really important tools. They're important for planning ahead and thinking about the actions that we need to take today in order to reach a future goal, while avoiding any catastrophic branches that would lead us down a path that we just don't want to have to go down. So because they take so many parameters, we're going to go over what this model in particular looks at. And I'll try not to move too quickly. If you do have questions, here's a good place to ask me. So
Eileen,
greater detail.
I'm going to ask you actually, why don't you just come forward? It's not picking up the audio very well, so we're going to give you a hall pass to move forward a little bit. So if you sneeze, don't sneeze at me. You just sneeze down and.
I'll sneeze down.
All right.
Okay.
Go ahead.
Maybe it's because I'm looking down. Sorry.
No problem.
Okay, so for the first parameter that we have there, it's population size. So we are considering the population in Minnehaha and Lincoln County. Is this better? Okay, good. This one, because I'm so short too. Okay, there we go. I'm gonna eat the mic now. No. The number of currently hospitalized, obviously that fluctuates from day to day, but we had to pick something. So 40 was the number that we chose. The date of the first hospitalization is basically the start of our modeling. We start March 20th, which was when at least Avera had their first hospitalization. The next three parameters that you see there, the hospitalization rate, the intensive care unit rate, and the ventilation rate, are they follow the rates that are stated in scientific literature, basically. probably this is probably the most complicated part of the model. But in our conversations back and forth with the healthcare providers as well as with the state, an acceptable range of between 0.5 and 1% of total infections was chosen to represent the hospitalization rate. So we picked a kind of a middle ground there at 0.8%, which may be slightly above what we're actually seeing at the moment, but it seems fair given the range of 0.5 to 1%. The model also takes into account the number of days that a person is infectious. That means the number of days that they could be spreading the disease, whether they know it or not. They could be, in general, I think we're seeing that you might be asymptomatic for 5 days, and then you start presenting symptoms. The average lengths of hospital stays, those obviously are numbers that the city, the city GIS department, we don't exactly know because we're not in the hospital system, but we use the Department of Health from Minnesota, which is regionally very near to us, and they publish their numbers. And in conversations back and forth with our health system and with the state, again, these numbers are not unreasonable. A hospital stay length of 13 days, 10 days in the ICU, 8 days on the ventilator on average. And the nice thing about this model is that they do have a parameter where you can take into account a percentage of reduced social contact, so social distancing percentage. We ran our model through 3 scenarios, one with no social distancing, one with 25% social distancing, which we consider to be what we're doing right now, and 35%, which is what we estimate could happen if we continue on with the stay-in-place ordinance that could take effect on April 24th. So running through those models, if we take a closer look, that first top really big spike there is what would happen, what we could expect to happen if we had not done any social distancing at all. And we would be peaking in just a few days here, but the number of cases, the number of infected population, that's what's on the vertical axis there is the infected population, would be very high, 110,000 around. And then the second blue peak is what we consider to be doing right now with a peak May 21st. If we start a 35% reduction in social contact on April 24th, we can expect that green curve to take place, and we would peak around June 4th. In terms of the stress that's placed on our healthcare system, the next 2 graphs are relevant. So the top, or the blue line, is our hospitalization census. So our model gives an estimate of how many hospital beds we would need. And that would peak on May 19th if we continue at the 25% social distancing, and ICU beds on the 17th and ventilators on the 16th. But the graph on the right is what it could look like if we implemented 35% social distancing. So just 11 more days, but the peak is reduced nearly in half. And I'm sure that would be much more comforting to our healthcare systems to know that they would need half as many resources to care for the surge that would be coming. Okay. So this is just in table format, the same charts that you were seeing, but basically tables. So if we had no social distancing, April 27th would be our expected peak with a number of infected individuals at 109,000. And the peak healthcare day would be April 25th, which is not that far away, but they would need 924 beds, which I don't think we are at that capacity yet. ICU beds at almost 190 and ventilated 115. So the next column over is the 25% reduction in social distancing, which I think we are doing right now, and it puts us at a peak of May 21st with 77,000 infected. And the healthcare systems would basically be at their max capacity on May 19th with 200 less beds needed, and 143 ICU and 87 ventilated. The very last column is our projected 35% reduction in social contact, peak June 4th, but with 40,000 infected, which is considerably less even than the 77,000 that we're expecting now. The number of beds could go down to 330, ICU 64, and ventilated 39. So I'm sure, because it occurs to me, that the next question you have is, how do we know that our current social distancing percentage is 25%? Well, that is an estimate, but we do use several different sources. So one of those sources is our own traffic count data that measures the number of vehicles traveling through 5 of the intersections in town, and it suggests that there's about 30% less traffic at those intersections. And another source that we have been, at the city, have been consulting is data from a marketing and an analytics company called Cubic. And this company tracks cell phone data they have a private network of partners, and where all the users have opted in to share their location data with this company. And the data remains anonymous. There is de-identification and large-scale aggregation of their data prior to any publication. And they offer that location and data free of charge and openly in response to natural disasters, urban development projects, and in this case, disease prevention. So for each county in the United States, they have released to the public a percentage change in mobility over the same period of time last year. And the GIS department has been tracking that information to consider in our estimate of social distancing. So I'm going to share with you another graph. This one is a little bit busy. It's kind of a lot to look at first, but I'll take the time to walk you through it in detail. So the blue bars here that you see are the total number of cases that we've been tracking since March 10th, which was when we found out of our first 5 cases in the state. And this is the number of cases in Minnehaha and Lincoln County. So it's not total state numbers, it's still just in our area. The light bottom blue on the bars, that represents the number of new cases that we're seeing every day. And all those little notes that fly out are the events that would be significant to our mobility or the progression of the disease. So things like, well, we had 1 death and 5 cases. We closed our offices. We had the no loitering and gatherings limited to 10 people. That type of thing, those are the notes that are popping out there. Those big dips that you see, so the orange and purple lines, are the percentage change in mobility for Minnehaha and Lincoln counties over the same day, but a year ago. And their data actually does lag behind a few days, so that's why it doesn't go up to today. It's kind of stops short on like I don't know, maybe the 13th there. But in the beginning of March, according to Cubic, our city traveled about the same, if not just slightly less than the same period in 2019. At the very top beginning of that line graph, we're just about the same. So the large dips that you see are weekend travel, and what we've really done well at is stay close to home on the weekends, and the data shows that we've been traveling nearly 70% less than those same weekends in 2019. So when we first started having put together our models, our mobility, and we discounted those weekends because there's just such gigantic dips, our mobility had decreased about 25% according to the Cubic data, and that data matched fairly close with our traffic counts, so 25 seemed like a pretty reasonable estimate to use for our reduction in social contact. So as you can see in the circled red there, from March 23rd through April 5th, that's about a 25% reduction in social contacts. So it is measured over the year before. But let's be honest, social distancing is actually really hard, really tough, and we did really well in those first 2 weeks. But the concern is, if you look at the red circle now, is that we are returning to near normal levels of travel, between April 6th and 10th. So if you think back to those first graphs that I showed you in the beginning with the curves, it showed just how big of an effect social distancing has on flattening that curve. And one of the concerns that we have is that a reduction in the percentage of our social distancing at this point in time, especially as more cases start to emerge, that could really alter the trajectory of that curve and essentially erase the gains that we've been able to make up until now. So another great question would be, how did we decide that 35% would be representative of the stay-in-place order that we're proposing? So that data comes from research from the University of Pennsylvania, and they investigated what varying levels of interventions had on social contacts. So on the very left, you see interventions. School closings reduced social contact by 4% for them. But the impact of that 4% less social contact ended up being 15% less critical care beds needed than if they had not had any social contact interventions in place. Restricting gatherings to 10 or less people had a reduction of 15% in contacts, social contacts, but the impact of that 15% was a 42% decrease in the critical bed needs compared to if they had no social distancing. And basically that last category that they have is combining everything. So school closures, along with restricting to 10 people and having non-essential employees stay home, ended up in a 31% reduction in social contact, and really a significant decrease in critical bed needs, down 65% from if they had no social distancing. And in our graphs, through our models, we follow that a very similar trajectory. So school closings and restricting gatherings to 10 persons ends up with about 60% decrease in critical care beds needed. And if we include all non-essential employees staying home, that actually ends up being a 70% decrease in critical care beds needed from the non-social distancing category. So it goes to show that while social distancing isn't easy at all, it is effective. And I'd just like to go back to that. Our curves, our models, basically the blue is where we are at now, and the green is where we could be if we implement a 35% reduction starting April 24th. I think that's it.
Elaine, thank you.
Questions?
Thank you. We will have questions. First, I'm probably going to let you take a seat because we'll probably have some people who maybe want to speak to this or have comments on this item.
Do you want me to lead that part yet, or?
Oh, I'm sorry, I passed
that's
the
fine.
gavel. You're in charge. Yeah, go ahead.
If we have public input on this subject in particular, come on up. All right, we'll go to questions from the council. Oh, hold on, somebody's coming.
You're standing behind the blue line.
Yeah.
Talk loudly. That's fine. I wasn't here. I'm sorry. I just got here. I'm Bridget Myers, and I live here in Sioux Falls, South Dakota. And I am asking you to please pull the shelter at home that you're planning on putting in.
That'll be the next. That'll be the next item. Is this for the data that was just? We're doing it item by item. So.
Okay. The data that was just pulled here. So I guess I just have a question then on it. Is that 35% then doing the ordinance that you're looking at? I was confused with the 35%. And is that what it is? Okay. I guess my question is, how come we have to show everything that's the most extreme? Do we have another model that shows a different version that would maybe be the minimum of what we're expecting instead of always showing the extreme on our graphs? Is there a way that we could show the minimums and the maximums? Because I feel like we only get like one version of what you're showing the public. There has to be more than just this model that can be shown. So my question is, if we're going to be presenting data, can we just present both sides, a minimum and a maximum? I also would like to see some economic impact that's happened, because I think we're at, what, 34 days that we've been in the stay-at-home order. I would like to see some data that actually shows the economic impact, that because the lives that you're trying to save from a virus is also going to impact people that can't pay their loans. The suicide rate that's going to go up in our city should be alarming to all of you, because people can't get loans. The money is out in the PPP loans. So I just want you guys to make sure that you're giving both sides of the thing to make your decisions.
Thank you. Come on up. And again, this is on the topic of data modeling that we just reviewed, so.
My name is Bruce Meyer, and if I see that chart correctly, is that modeling with 25% and 35% talking about 10,000 on April 24th, about 10,000 infections, and that's in the Sioux Falls area? Is that correct? Is that what that says? I can speak to that. Okay.
So yes, this is the number of infected population, and it is confusing. It's because basically it includes, it's not just confirmed cases. This is from the literature, the scientific literature. It includes people who are mildly symptomatic, who may never get tested, and also those people who are asymptomatic. And so how do we know that? Basically, we've had a few countries that have done extensive testing. So South Korea, New Zealand, Iceland, and incredibly enough, if you were on that Diamond Princess cruise, that was like a science experiment made in heaven. I don't know. Not great because people died, but they tested everybody. Like they maybe didn't test, I don't know, 100 people. They tested more than 3,000 people. And so it gave them a really good idea of those who had COVID but didn't know it. And so what we're seeing from those countries who are extensively testing everyone, whether or not they are presenting symptoms or not, is that that 0.8% is the number of total infections that will actually end up hospitalized. So it doesn't represent confirmed cases. So yeah, if you're looking at this graph now and looking at April 24th and thinking, oh, we should have 10,000 cases, that's not the case. That is 10,000 people who are likely infected, but it does not include, it is not people with confirmed cases right now.
Thank you.
And actually, it ends up being about 10%. So if April 24th around, so that's 10,000, it's about 1,000 cases. We're actually running a little higher than that right now.
Okay, so taking your numbers that say we may have 10,000 people in South Dakota that might be infected and not know it, our actual numbers are about 1,165 or 1,400 to 1,300, something like that in the Sioux Falls, not South Dakota, in the Sioux Falls area. And I dispute on the 25 and 35% models. I see most people in Sioux Falls having masks, having gloves, staying at least 6 feet apart. I have 100% social distancing from my grandchildren for the last 30 days. And I think that our estimate is way low on the social distancing being practiced. And the other number that you had up there before was about 100 beds would be needed. So far, totally, we've needed 40 beds. And maybe 8 people in ICU. So what we're doing is either working, or the people that may have this infection are immune, have a natural immunity, and I think the models are something that are so abstract that we have to start looking at the actual numbers. How many do we actually have? And I don't think these represent that at all. I think we have much lower numbers actually and much higher social distancing based on everybody that I see wearing and using these and keeping their space.
Thank you. Anybody else with public input on this item? Welcome.
I'm Corey Hansen, and I'm trying not to lead into the next discussion. I am encouraged by one thing on this, that April 16th, and these pages aren't numbered, but on one of the graphs, which he showed, the cases actually went down on April 16th significantly. It looks like maybe 25% of new cases. And I don't know if that's correct, it shows this. So I'm encouraged by that just because of the meeting that you guys had Wednesday night. It might have put some people to say, hey, we just need to do a better job of what we're already doing. That part will lead to the next thing. But the one chart too, it's 30 days old. I mean, it's March 18th when we have the one graph on there that says, what is 35% social distancing? And I know this is a really fluid thing we're going through, but that's 30 days old. So we're using 30-day-old information. And I agree with the other couple of people, because where's the charts and graphs that are talking about, you know, the employees that are being sent home that are in depressed situations and turning to alcohol and drugs and all kinds of really, really bad things that can't pay their bills? We're not using those charts. I don't know why, unless there's an agenda that we have. And Paul, you said earlier that already, without doing what has been discussed Wednesday, that the hospitals, quote, feel like they can meet with our current model demand, which is what we're doing now, that we can already, they feel like they can meet it. So I don't want to get too far ahead of myself into the next discussion, but that's the stuff that I just had questions about the data. I don't know if we need to answer or not, but I just like more data and more current data.
Jim.
Thanks.
Thank you.
Good afternoon. I look at this data and compare it to
State your name, please.
Troy Jones, I'm sorry. I'm in business. All my businesses are essential businesses, so all of your rules do not affect my business. It's an issue of what's best for the city. All of these models, I like the fact that where they started. They do start from some epidemiological baselines, and they're right with regards to whether you have a 10 confirmed case, total cases that are out there, what is out there. Now, and then you project out. But then you adjust all of your formulas based upon what you know that is actually occurring in the area. And I'm not seeing anything there. And if I take all these extrapolations after just one look at them, these mirror very close to New York in some ways, and some ways they don't. For instance, they have 450,000 tests or something like that, and about half of them came in. They have a 2-to-1 ratio between tests and confirmed. We've got a lot different ratio. Those things do impact out there, because when we have a 10-to-1 ratio, that means we do not have as many random out there. It gives you an indication of you can't project out to be like New York. New York, when they ran into their hospital problem, they had 31,000, or got to their max, and then it declined. They got to 31,000 hospitalizations. On a per capita basis for New York City, for Sioux Falls, that would be 1,000. So, and then when you do the 10 days, they're in the hospital for 10 days or whatever, your number at about 700 is pretty darn close. So for those numbers to be what we're going to hit, we have to have a experience just like New York had. What's different about New York? You adjust them for what's different. New York, 77% of their people go to work in public transportation. They're touching everybody all the way to work. They live in multifamily housing. We have 95% drive to work. We do not live in the same kind of housing. So we do not have the day-to-day contact to repeat like New York with regards to the spread to what these numbers would say, and maybe we'll find that out. They have 2.5 million people infected in New York. That's comparable to us getting 77,000 in the same time frame. But we don't have the environment they have. So the odds of us getting 77,000 means we have to do a lot of things bad. Number two is what really affects our hospitalizations. This is you also have to adjust this off of ubiquitous. The COVID attacks a certain people very harshly, worse than anything else. I went through every other types of infectious diseases, and they don't hit particular profiles, diabetes, obesity, all those things as high as COVID is. On the flip side is, with regards to these percentages, is that if we were to use the same thing, that means everybody that's healthy is affected a lot less. So you combine those two things here is, if we really want to stop hospitalizations, we put people who are vulnerable in a place where they're not going to run into somebody. And then we do everything we can to accommodate them. And right now they're under an executive order. So I then ask the question is that if they're under executive order, segregated from us, what the rest of us do, how does it affect them? How does it affect those people that will drive our hospital numbers? But we might be getting affected, but it's 1 in 1,000 will present ourselves to a hospital versus 20 to 40% if you're vulnerable. So we'll be getting herd immunity. The sooner we get herd immunity, they can come out of their houses, they can interact with us, and they're not stuck in their homes. If we keep spreading this out, they are segregated from us longer. So you have to manage not to have more deaths, but you manage to get them to live among us as soon as possible. So with that said, we've done a great job here flattening our curve. We might have done such a good job flattening our curve here is that we've already extended it to some point. We may be above the 25%. So my point is we have to be very cautious about whether we want to do more things because it has negative effects. Beyond the economic, it has an effect on when we're going to get back to normal. And so aggression. Now, the other thing is, I don't know, and I missed, and I didn't follow, still processing some other things, what we're going to do for this 35%. The more coercive it is, one of the things that the CDC says with regards to all the coercive actions, they have about a 2-week shelf life. And we've already been pounding on some things on voluntary coercion.
Thanks, Troy. We're at our 5, so.
Okay.
Thank you, sir.
We've been pounding down on some of our coercion, so I'm not sure how much more discipline we have. We have to be very careful about that, because if we do get the spike we don't know about,
Thanks, Troy.
capacity to pound around. Thank you.
Thank you. Anybody else?